are. So it is March 20th, 2020 in our strange new world. As it turns out, Lindsay, we had this webinar planned for a couple of months already, but all of a sudden here we are. And as you and I were talking a couple of minutes ago, you've already seen an uptick in the number of abuse cases reported. And it's a very sad part of the unintended consequences of all this. So Lindsay and I met in the context of her being a faculty member at Rutgers who was interested in learning more about PCIT, parent-child interaction therapy. We got to know each other well, and I got to learn more about some of her other specialty areas, which include doing TF-CBT and working with kids and families who face trauma. I'll let you do as much of an introduction as you like beyond that, and I'll turn the floor over to you. Our pro forma that everybody knows is that I'll be on mute by and large, and then I will flash you 15-minute sign, 10-minute sign, whatever, and we'll make sure that we leave 15 minutes for Q&A. But we're now up to 1,000 attendees, not literally, but we got a lot. So thank you for sharing your time and your expertise. I'll take myself off and let you get started.
Sounds good. Thank you, Steve, for welcoming me here, and I'm excited to be here. I hope everyone is doing well given the circumstances. And like Steve had said, we had planned this workshop a long time ago, but unfortunately, given the current circumstances, I imagine that it will be even more applicable in the months and year ahead, given that more children are home without childcare, and parents have a lot of stress going on in their lives right now. So today we're going to be focusing on trauma-focused CBT, specifically the trauma narrative and the cognitive coping portion of trauma-focused CBT. As Steve said, one of my areas of specialty is trauma work. I'm the supervising psychologist at the Metro RDTC at Newark Beth Israel Medical Center, and we're still there. We're still working through this all because unfortunately, a lot of times, children, when they're not in school, trauma does increase during these times. So at the Metro RDTC, what we do is we provide expert services, medical and psychological services to children who have allegations of sexual and physical abuse and neglect and all forms of maltreatment. So we provide psychosocial evaluations, which are forensic evaluations after an allegation comes into DCPMP, Child Protective Services in New Jersey. And then we also provide therapy for those children. In addition to that, I also am the owner of Caring Cove, which is a private practice in New Jersey that provides evidence-based treatment to children and adolescents. So I'm going to go ahead and get started. So the goal of this presentation is really to help clinicians provide a rationale to caregivers and children on why trauma narratives are an important part of treatment. I know in doing this work, a lot of times we get asked by families why we have to continue talking about a traumatic event that happened and why we can't just put it aside and try to forget about it. So my hope is that this presentation will provide some strategies for how to answer those questions. Also, you'll be learning 3 goals for completing a trauma narrative and how to encourage clients to complete detailed narratives and how to challenge cognitive distortions related to trauma. So before I actually get started on going through all of that, I wanted to thank the developers of trauma-focused CBT, Esther Devlinger, Judith Cohen, and Anthony Manarino, because obviously this presentation and all of the wonderful work that has been done with trauma-focused CBT would not be possible without them developing it. Trauma-focused CBT is an evidence-based approach that was developed to assist children and adolescents and families who've been impacted by trauma. It's for all types of trauma, so sexual abuse, physical abuse, domestic violence, things like what's going on right now in the world, all sorts of anything that you can really think of that's traumatic for a child. Trauma-focused CBT helps to address that and the symptoms that occur. So Trauma-focused CBT is empirically supported. There's over 25 scientific studies that have shown that trauma-focused CBT helps reduce the symptoms that children experience following trauma. And there have been over 20 randomized controlled trials. Trauma-focused CBT is really considered the gold standard. So if you have a child that's presenting to your office with a trauma history, trauma-focused CBT is really the way to go. So the core values of trauma-focused CBT are, it spells crafts. There's a lot of acronyms within trauma-focused CBT, like many approaches that we are all familiar with. And the first one I wanted to highlight was crafts because it highlights the core values. So trauma-focused CBT is components-based. It's respectful. So when I say respectful, what I want to highlight is that when working with families, especially families that have been impacted by trauma, it's really important to consider the culture and the religious background of those families and make sure that the approach that you are taking with the family is really in line with their values. It also is adaptable. So as the clinician, your judgment, your clinical judgment is really so important. And you want to make sure that you're individualizing the approach for the family. It's also family focused. One of the key ingredients of trauma-focused CBT is the caregiver's involvement. So it's very important that you do have a caregiver that can participate, although that comes with a caveat because trauma-focused CBT has also been shown to be effective when you don't have a consistent caregiver that is involved, but ideally you would have at least one caregiver involved in treatment. The therapeutic relationship is at the center. If you don't have a relationship with the child and the family, the chances of them opening up to you, especially about something like trauma, is very minimal. So it's really important that you've established rapport with the family, with the child, and the caregiver. And it's self-efficacy focused. So one of the biggest components of trauma-focused CBT is that you're helping kids develop mastery on foundational skills before moving into the trauma-focused or the trauma narrative rather. So kids really develop a lot of confidence in their own ability to overcome the traumatic experience that they experienced rather than seeing themselves as victims. They rather see themselves as survivors. So when is trauma-focused CBT appropriate? It's appropriate for children between the ages of 3 and 18. And it's important to highlight that this is the developmental age of a child. So a child who is, let's say 4, but developmentally 2, it would not be appropriate for. It also is important for children who have a known, or is appropriate rather, for children who have a known trauma history and have memory of that trauma history. So let's say a trauma happened before the child was 2 years old and they don't, or 3 years old and they don't have any memory of the trauma. This would not be the best approach. It is also important that the child has trauma symptoms, and we can talk a little bit more about these trauma symptoms in future slides. But when considering whether trauma-focused CBT is appropriate, you want to make sure that the child is not actively suicidal. You also want to make sure that their behavioral difficulties are not at an extreme. So what I mean by that is the behavioral difficulties shouldn't be dangerous to themselves or to others at the time of treatment. If they are dangerous to themselves or others, and another treatment approach might be more appropriate to start with. And we could talk a little bit more about that in the future as well. You also want to be able to see a possible link between their trauma symptoms and the traumatic event, or their symptoms more generally. So lots of times we ask caregivers, did these symptoms start after the traumatic event happened, or were these symptoms that the child was experiencing that predate the traumatic event? Sometimes it's impossible to be able to differentiate between those things because the traumatic event happened earlier in the child's life. But other times we can see a clear link between the traumatic event and the current symptoms the child is experiencing. The other component you want to consider when thinking about whether trauma-focused CBT is appropriate is if the child is safe in their current environment. If the child is currently not safe and is still with, let's say, an abusive caregiver, then trauma-focused CBT may not be the best approach for that child. So I've personally seen trauma-focused CBT be effective in clinics, in schools. I did trauma-focused CBT in a residential treatment facility, in inpatient centers. It's been effective. So you can really use trauma-focused CBT across settings, which is wonderful. So trauma-focused CBT involves both the caregiver and the child, and there are caregiver and child individual sessions that occur each week. So in the beginning, the conjoint time, this in the Venn diagram, the time in the middle, is really at a minimal. It's really there to help the parent and the child practice skills together, and that conjoint time expands when you're doing the trauma narrative sharing component of the treatment. So in the beginning, you really are meeting with the caregiver and the child individually, and lots of times the session is broken up almost equally, and the same clinician would be providing treatment involving the child and the caregiver. So like I had just said, that the conjoint parent-child sessions really in the beginning focus on practicing skills together, modeling appropriate child support. You want to teach the parent behavioral modification strategies, and then have the parent and child together and have the parent practicing those behavioral modification strategies right there in the session, so that you can coach during the session on how the parent can make modifications. The goal of the conjoint time in the beginning is to increase positive interactions and effective communication between the child and the parent. You also want to help the parent prepare for future traumatic reminders. So during the beginning phase of treatment, which is assessment, you're going to be identifying traumatic reminders. And those traumatic reminders, the parent is going to have to help the child cope with outside of sessions. So you want to make sure you're preparing the parent to do that. In later sessions of trauma-focused CBT, you'll also be having the child, if appropriate, share the narrative with their parent. And then, of course, my favorite part of treatment, you'll be celebrating at the end with a graduation ceremony with both the parent and the caregiver. So the target of trauma-focused CBT, also another acronym, the same acronym, CRAFTS, highlights the areas that trauma-focused CBT focuses on. And those are cognitive problems, relationship problems, affective problems, family problems, traumatic behavior, and somatic problems. So you'll see that trauma-focused CBT really addresses all of the symptoms that kids present with following a traumatic experience. So the most important part in the beginning of treatment is obviously the assessment, and therapeutic engagement starts during this assessment phase. And you actually won't be able to do a detailed narrative unless you do a thorough job during the assessment phase. So this is the first strategy for helping kids create detailed narratives. And during the assessment phase, you want to make sure that you're asking about prior experience in therapy, because that has been found to be one of the, and some would argue, the most important obstacle towards treatment engagement or therapeutic engagement. If a parent or a child has a prior history with therapy or with a clinician that didn't go so well, they may be less likely to engage. So you want to address any prior experience in therapy the child might have. You also, of course, want to ask about the traumatic events and the child's current symptoms. And you want to ask when is the child reminded of the traumatic experience most? So I have had kids tell me that at school, they'll be in class and their teacher who reminds them of the person who abused them will be talking, and all of a sudden they'll have a flashback related to the sexual abuse that they experienced. Or kids who are on the playground, they might be having more behavioral difficulties because of the volume on the playground, and they could be hearing that volume, their peers talking and their teachers talking at a higher volume, and have a flashback related to an exposure to domestic violence. So you really want to start to understand, when are the children most reminded about the traumatic experience and how is that impacting their functioning? You also want to use standardized a battery of measures to assess the child's symptoms. And then most importantly, after giving, let's say, the UCLA or the trauma symptom checklist or CBCL, you want to review those symptoms and the elevations that have been determined by the measure. You want to review those elevations with the child and with the caregiver, the child depending on their age. And when you're reviewing it, you can actually start reframing for the parent during the assessment phase by saying things like, wow, I'm actually really happy to see that you have clinically elevated scores on the PTSD index, because now we know where to work. And these symptoms are actually really common following the event that your child experienced. So you can normalize the symptoms that the child is experiencing and help the parent understand them within the context of the traumatic event the child experienced. You also, during the assessment phase, want to ask the child to give you a neutral narrative. So tell you about a time that they felt happy, and you'll want to prompt them for how they were feeling and what they were thinking. And you can even say to them something like, tell me about your lunch or what you had for lunch, and tell me about what you were doing and what you were talking about and how you were feeling and what you were thinking, because you want to be able to determine whether the child can tell you a story with a beginning, middle, and end, and provide information related to their thoughts and feelings. You also want to get a baseline trauma narrative. So lots of times clinicians avoid talking about the trauma this early in treatment. And trauma-focused CBT tells us that we really want to start talking about the trauma as soon as the child comes into our office at that very first appointment. And then you want to talk to the caregiver during that individual time that you have with the caregiver about how children frequently will report an increase in symptoms at some point in treatment, specifically when they start talking more about their traumatic experience. And that's something that we should expect and predict, because when we predict that for caregivers, our credibility, the parents will understand that we know what's going on, we've seen this happen, and we can instill hope in the caregiver by saying that even when symptoms increase, the child will then later report a decrease in symptoms. And we want to see that increase because it shows that the child is really working through their traumatic experience. So there's lots of different components of trauma-focused CBT, and we're going to specifically be talking about gradual exposure and each of these components. So obviously we don't have enough time to go through each component in its entirety, but the gradual exposure piece of each component is the important piece that leads us up to the trauma narrative. So the trauma-focused CBT components spell practice, and the first component is psychoeducation and parenting skills. The second is relaxation. The third is affective modulation. And you'll see that cognitive processing and trauma narrative are the two areas that just got bigger, and that's because those are the areas that we're going to be targeting. Before we go into each of the components, I wanted to highlight the different phases of trauma-focused CBT. And those three phases are stabilization, trauma narrative phase, and integration. So the stabilization phase is composed of psychoeducation and parenting skills, relaxation, affective modulation, and cognitive processing. And then the trauma narrative phase is obviously comprised of trauma narration and processing. And then the integration phase is in vivo exposures, conjoint parent-child sessions, and enhancing safety and social skills. So you'll see in the pie chart on my right that each of these phases is equal in duration. So lots of times clinicians think that the trauma phase will actually be the longest phase, and or the longest phase of treatment, and that's not true. The stabilization should be 1/3 of treatment, the trauma narrative phase should be 1/3, and integration phase should be 1/3. The only time that you would see the phases not be equal in length is if the child has a complex trauma history. And if that's the case, you actually would spend more time in the stabilization phase because you want to ensure that the child has reached mastery in those areas and has the foundation skills to proceed forward with the narration. You also don't want to spend too much time on the trauma narrative portion of treatment because that can actually lead to rumination if the child is spending a large portion of treatment talking about what happened in the past rather than what's happening in the present or what could potentially happen in the future. So like I had suggested a couple of slides ago, gradual exposure is really the key ingredient of the treatment and happens from the very first session with that assessment phase. And we want to make sure that we are providing opportunities for gradual exposure during that stabilization phase. So with the psychoeducation, with the relaxation, with the affective modulation phase. And you'll see on this chart that we really want it to be a gradual process rather than going from cognitive coping to the trauma narrative, and the trauma narrative being the first time we're actually mentioning the traumatic experience. I always think of a funny interaction I had with a client that at the time wasn't so funny, but looking back on it was funny. I was in the assessment phase of treatment and I had asked her about prior experience with therapy, and she was in treatment for a really long time. And I had said to her, so tell me about the times that you spoke to that therapist about your trauma. And the child, who was 8 years old at the time, kind of giggled and said, oh no, I didn't talk to her about it. She wasn't ready to hear about it. And I thought that that was an interesting perspective from a child, that she had internalized the belief that her therapist even could not hear about this traumatic event that happened to her because it was just too significant. So even though she had been in treatment for a really long time, she didn't bring this up, and she didn't believe the therapist brought it up because she thought the therapist just wasn't ready to talk about it. So it's our job to show kids and families that we can talk about the things that have happened to them from the very beginning, and that we're okay talking about it. And actually, we're better than okay talking about it. We're proud of them for talking about it. And we think that they're brave, and we think that they're resilient, so that we can start really instilling hope from the very beginning. So in terms of gradual exposure and psychoeducation, in the beginning, when you're doing the assessment, during the assessment phase, you're obviously going to be identifying different symptoms the child is experiencing, and then you'll use the results of those assessment measures to lead the discussion related to psychoeducation. So you'll look at the child's profile of symptoms and speak about how trauma frequently looks like this in children, and how the way the child is experiencing is very common given the circumstances that happened in the child's life. You'll also want to use the real terms for the type of situation the child went through. So lots of times we might be tempted to say things like, oh, the bad thing that happened, or the not okay thing that happened. But during psychoeducation, we want to say when you were sexually abused or when you were physically abused. And then we want to define what sexual abuse is for the child, or what physical abuse is, or neglect, or exposure to domestic violence, or whatever the traumatic experience is for the child. We also want to use the real names of the body parts, so start saying things like penis and vagina, so that the child knows that we can and we're comfortable talking about the body parts, and that they don't need to be embarrassed or ashamed. We want to provide general information about trauma, and then we want to review the child's symptoms and how they may or may not lead to a diagnosis. So not every child who is referred for trauma-focused CBT has a PTSD diagnosis, but if they do, we want to make sure that we go through that diagnosis and what that means. And then in the beginning of, or during the psychoeducation phase, we want to make sure we're already explaining why we need to talk about trauma. We're already explaining why the trauma narrative portion of treatment is so important. So we can use different analogies like cleaning a wound. So most kids understand that even though when they have a cut, it might burn if we clean it, it's important to clean it because we don't want it to get infected. So similarly, we need to talk about the traumatic experience because we don't want their symptoms to get worse. And if we just make believe it's not there, similar to a wound that's not cleaned, it could potentially get infected. We also want to provide an overview of the treatment and what the treatment is going to look like. And we could use different games, like in the corner of the screen, you'll see the What Do You Know game. That's a game that's used to review psychoeducation related to trauma and abuse. Then during the parenting skills portion of treatment, we're going to be meeting with the caregiver like throughout all the other components individually. And we want to be practicing behavioral management skills, but not just behavioral management skills in general, but how they're specifically linked to the behaviors the child is displaying now after the traumatic experience. So we want to make sure that we're helping caregivers link the child's behavior to what happened and address it in an appropriate way. So lots of times caregivers will come to our office and will say that that they really just want to put their child in a bubble because it's not safe in this world. And it's important for us to highlight that even though this traumatic event happened, it is really important for the parent to be consistent and to set clear expectations and to be predictable in their behavioral management techniques so that the child doesn't interpret their actions to suggest that whatever the child experience was actually the child's fault. So for instance, if let's say the child was sexually abused and the parent all of a sudden creates an environment that's very restrictive, the child might think that the parent is punishing them for the abuse because they did something wrong. We also want to highlight for the parent that they're modeling for their kids how to cope and how to express their emotions. And it's really important that they practice the same skills that we're going to be practicing with their kids at home. And if a parent ever asks you, what do I say? If my child says, you know, I'm so sad that my uncle touched my private part, how can I even address that if I don't even know what to say if my child said that? The one thing that you can always suggest the parent does is just reflect it back to their child so that their child knows that they heard them and they're listening. We also, and I'm going to move a little bit quickly through these components so that we can get to the trauma narrative portion, but we want to make sure that we're teaching children how to cope with their traumatic reminders across situations. So what coping skills can they utilize when they're reminded of the traumatic experience at school, at home, on the playground? And then we want to have them practice those skills. So you'll notice that through each of these components, I'm highlighting how we're talking about the trauma. Trauma is something that is woven through every component of treatment. So we also want them to identify how they're feeling related to the traumatic event. And so we'll ask them, when so-and-so gave you a not okay touch, or when mommy died, how are you feeling? And what were you, what are all the feelings that you were feeling, not just sad? Because sometimes kids will say sad and then they'll want to move on, but there are usually a lot more feelings that they're not sharing. So now this is the component that one of the components that I really wanted to focus on is cognitive coping and processing. And this is actually the only time in trauma-focused CBT that you will not be talking about the trauma with the child. So you want the child to start realizing the difference between their thoughts, their behaviors, and their feelings related to innocuous events rather than the traumatic event. And the reason why we do that is because sometimes children will then filter. If you start talking about the cognitive distortions they're experiencing related to the trauma, they'll filter those distortions out of their narrative. And we don't want them to filter their narratives because we want to be able to process it in its entirety when we get to that portion of treatment. However, we do talk about trauma-related cognitive distortions with the parent at this component of treatment. So we can already start challenging those distortions with the parent, but we don't challenge those with the kid. So when we're thinking about some cognitive coping with caregivers, there are some specific strategies that you can use during this portion of treatment. The first thing that I want to highlight is we don't want to forget to provide labeled praise for helpful or functional trauma-related thoughts. Lots of times we focus on the distortions, but we may not highlight the things that are appropriate and helpful to the parent. So if you hear thoughts like, I love my child, I do anything for my child, I think my child is amazing at the way they're able to cope with this, you really want to recognize those thoughts and provide lots of labeled praise. If you hear unhelpful or inaccurate thoughts, you could use Socratic questioning and really assess the evidence and have the parent assess the evidence for a specific thought. And you want to be able to identify permanent, pervasive, and personalized thoughts and other thinking mistakes with the parent. So during this cognitive coping portion of treatment, you really want to make sure that you are highlighting when you're seeing thinking errors. And if a parent is stuck on a thought, some questions you can ask them is, would you say that to your best friend if your best friend's child was sexually abused? So for instance, if a parent says to you, I'm a terrible parent because I let this happen to my child, I would ask the parent, if your best friend told you that their child was sexually abused, would you tell them they were a terrible parent? You'd also, another thing you can ask a parent is if they would want their child to overhear them saying the things they're saying to themselves. And most times parents at that point will say, no, of course I wouldn't want them to hear that. I don't want them to hear that I think that I'm a horrible parent, or that the world is, that you can't trust anyone in the world, or that nowhere is safe, because I don't want my child to feel like they are never safe. So those are some questions that you can ask during the cognitive coping phase with caregivers. Now, when we move on to the trauma narrative, there are a number of goals that you can think about. And one is you want to, during the trauma narrative phase, you want to make sure you're minimizing or extinguishing, rather, intense negative emotions the child has related to the traumatic event, and specifically the trauma reminders, because we don't want kids to be feeling sad or angry or guilty or shameful every time they're reminded of their traumatic experience. We want to create new positive associations. So lots of times my colleagues will say to me, it seems like you're always having so much fun with the kids that you're working with. And that's because even though we're talking about really hard material, we want to make sure that we are having fun and we're reframing or redefining the traumatic event for the child so that they now see this as something they can overcome and they're resilient and that they can have fun while talking about it. And it's just one piece of their story. We want to also, during the trauma narrative phase, make sure that the child has gained mastery over their trauma reminders. So we want to make sure they know when they occur and what they can do when they do occur. What coping skills can they utilize? How can they express how they're feeling? We also want to resolve any avoidance symptoms. So lots of times kids, when they start thinking about something, they'll related to their traumatic event, they'll want to push it aside, similar to trying to hold a beach ball under the water in a pool. If you let go of that beach ball, it's going to pop up. And so I'll use that analogy with kids and I'll say that when we try to avoid, we're trying to push down our feelings and those feelings are going to pop up. So we want to give them new strategies, new coping strategies. And we want to see whether the coping strategies that we practice during the stabilization phase are helpful when we're talking about the traumatic event during the trauma narration phase. We also want the child to realize that this traumatic experience or these traumatic experiences, because we know that kids have multiple traumatic experiences lots of times, are only one piece of their story. So you'll see in future slides that the trauma narrative includes a chapter at the beginning and a final chapter that is not related entirely to their traumatic experience. And the number one goal is we really want to improve quality of life for the family. We want them to be able to, after this trauma narrative portion of treatment, to put this traumatic experience in a different category and move on with their life without having to avoid talking about the traumatic experience, but rather just seeing it as one element of their life. So when I'm explaining the need for the trauma narrative, I use a lot of analogies with both children and caregivers, and you want to make sure that you're providing the rationale for the trauma narrative in separate sessions. So you'd be talking to the child and the caregiver separately when you're describing why we're doing the trauma narrative. You also don't want to bring up the sharing component of the trauma narrative until after the child has completed their narrative and you're sure that it's appropriate. You're going to be assessing throughout the narrative portion of treatment, and also you've already been assessing throughout the stabilization phase of treatment whether the parent is going to be able to hear the narrative. Not in all cases do you share the narrative. So some analogies that I use when explaining the trauma narrative to children are listed on the slide, and I could go through some of them. One that I find to be really helpful is the filing cabinet one, or packing for vacation. Lots of times, depending on the family, the packing for vacation is helpful. So I'll explain how if we throw all of our stuff into a suitcase and try to close it, lots of times it's really difficult to close the suitcase, but if we organize it, it's easier to close the suitcase. And similarly, the trauma narrative portion of treatment allows us to organize our thoughts and our feelings and our experiences related to the traumatic event so that we can close that suitcase and move it aside. But if we don't organize the events, then it's much more difficult to put the experience aside. And lots of times the reminders related to the traumatic event will pop up in times when we don't want them to pop up. Like when we're at school or when we're on the playground and something reminds us, and then our behavior gets in the, maybe we'll act out or start crying or avoid or dissociate. And instead of doing that, following the trauma narrative, lots of times kids are able to talk about the traumatic event and not avoid and not be afraid that it will pop up at less opportune times. Also, I'll talk to them about how on a roller coaster, lots of times before we get on a roller coaster and when we're waiting for it to take off, it's really scary at first, and the trauma narrative might feel that way at first, but then at the end of the roller coaster ride, we usually feel relieved that we went on it or happy that we went on it. Of course, we want to first make sure that the child likes roller coasters before we use that analogy. Another one is holding an inflatable ball underwater. It could hold the ball underwater or those memories underwater, but it would take a lot of effort and we would miss out on our life if we spent our life trying to hold the ball underwater. And as soon as we let go of that ball, it would float to the surface. So similar to holding a ball underwater, we don't want to use all of our effort in holding our memories related to a traumatic event underwater, because as soon as we let go of that ball, it will pop up. So caregivers usually are on board at this portion, during this portion of treatment, because of all the work that was done during the stabilization phase. They also understand that they'd rather these memories pop up when a child is in session with me, rather than if they're at school or with their teacher, or at times that are less predictable. When we're explaining the rationale for the trauma narrative to the child, we also use books like the one you'll see on the slide, which is Please Tell a Child's Story About Sexual Abuse. There's all sorts of stories for different traumatic events. And this helps us show kids that other people have written about this experience or their experience, a similar experience, and are okay at the end of it and are happy they wrote about the story. The key is that when we start explaining the rationale behind the trauma narrative, we want to then immediately start the trauma narrative. We don't want to do this one session and then hold off to the trauma narrative the next session, because then kids might be more avoidant of coming to that session. When we do the trauma narrative, we want to give choice. So kids can have a poem or do a book. And we want to start the trauma narrative by saying, tell me about the first time, rather than giving them a question or an indirect command, like, can you tell me about? So we want to make sure we're giving a direct command and providing labeled praise for effort, not the disclosure. So we don't want to praise disclosures because that could get tricky if we're ever testifying in court, but we want to make sure that we are praising effort. And while the child is creating the narrative, we can help them add details by asking clarifying statements, like explain the part about, or tell me more about. I wasn't there, so can you help me understand what happened? Tell me more. And we also want to go through and ask them what their feelings were, what their thinking was, what happened next, and how their body was feeling. So when a child creates the narrative, the first pass at the narrative is free flow. They just say whatever they're thinking and tell the story. And then we go back and read the story in future sessions and then prompt them for additional details for each pass of the story. And if they're ever having difficulties with sharing information, we explain the rationale for the treatment again, or provide the rationale. We can help them by using coping skills before or after the narrative. Once again, we can offer them choices. So they could even sing the narrative or create a poem. The product isn't so important. It's the process that's the most important. We can also get excited about the cover page and the illustrations. And we want to end each session with a positive ritual so that the child has a chance to regroup. And of course, we're always assessing their distress throughout the narrative portion of treatment. And this is a cover that I added to the slide of one of my clients that a parent signed a release for me to have it on this slide. And I love this cover because the child actually had a different cover at the beginning of their narrative, and it was I'm scared was the title. And they ripped up that cover page at the end because they said that they knew better now, and whoever was reading the story, they wanted them to see a different cover page, which was "Don't worry." So you'll see that the cognitive distortion, or a lot of the distortions that were addressed, ultimately led to the change of the cover page. So without going into great detail about the breakdown, you're going to have different chapters of the trauma narrative, which you'll have general information, then you'll have what happened before the trauma, what happened during the trauma, and then you'll have a final chapter. And after the child has created their narrative, before the next session, you want to make sure that you're reading and the narrative independently of before your session and highlighting any unhelpful or inaccurate distortions that you see, and writing down any possible replacement thoughts that you would like the child to come to, and what types of questions you can ask to help the child get there. So it's really important that you do this work before that session so that you're prepared. And then when you're reading the narrative with the child, you want to provide labeled praise for any time they shared feelings or any helpful thoughts that they have or accurate thoughts. And then you want to use strategies like being a talk show host, or having the child role play with their best friend, or the child being the therapist, to really challenge some of the distortions that you see. So this is an example in a narrative that I had with a child, and this was the before portion of the, or before chapter in the narrative, where the child says that I was in a family room watching a movie, and the child's mom was at the store, and then he came in the room and sat close to me. I should have known he was going to do something wrong and stopped him. So this was the first pass. The child provided this information without prompting, or without a lot of prompting from me. And then you'll see during the second pass, I had prompted the child to provide their thoughts in this situation and feelings. And I had highlighted before the session a potential distortion that the child had. And the distortion was, I should have known I was going to do something wrong and stopped him. So some possible questions that I could have asked this child would be, how would you have known? Has anyone ever sat close to you on the couch before and did something wrong? Is he bigger than you? So you want to be able to ask the child questions to see if they're able to reframe or rewrite that sentence. And in this particular case, the child ended up saying, at the time I should have known, but now knowing what I know now, it wouldn't have been common for me to have known that he would have done this to me, because lots of people have sat next to me and have not hurt me, and I would not have been able to stop him. So kids can then cross out parts of their story and rewrite it.
So I know you got a bunch of slides left, and we're going to try and balance and make sure we have Q&A time, because we do need to stop promptly on the hour.
Okay, perfect.
So if you want to prioritize what you do, and then let me know when you're ready for Q&A.
Okay, sounds good. So I'm not going to go through all of these trauma-related distortions that you could potentially see, but these are some of them in children and in caregivers. And you want to make sure caregivers realize that the way that they perceive themselves and the world and others will really impact how their children perceive themselves, the world, and others. So this is an example of how to address one of the distortions on the previous slide. And one strategy is the responsibility pie. So lots of times kids will think that it's their fault for a specific type of abuse. So this child said, it is my fault, my uncle sexually abused me. And what you want to do is ask the child, what are other contributing factors that could have influenced their uncle sexually abusing them? And in this particular situation, the child created a list of reasons, like it was a female in this particular situation, that her uncle was sick, that her uncle needed help, that her mom wasn't there and had to go to work. So after creating a list of other possible explanations, you want to work with the child to create a responsibility pie. And you'll see at the end, the child was able to see that they really had very little responsibility. And the reality is they weren't responsible at all, but this was the end of this child's responsibility pie, where they saw that they had a very slim portion of responsibility in the sexual abuse. So I'm not going to go through the caregiver session goals because we went into this in a little detail, but if anyone has any questions about this and wants to email me, my email is at the beginning of this PowerPoint, and you can feel free to email me some about strategies that you could use with caregivers during the trauma narrative portion. So when we think about sharing the trauma narrative, some things I want to highlight is that you want to be assessing whether the caregiver is ready to hear the narrative throughout the entire treatment. So is the caregiver providing supportive statements? Is the caregiver able to believe the child? So for instance, if the caregiver is still not believing the child that an abuse happened, then you may want to rethink whether the child is sharing the narrative. And at the beginning of sharing the narrative, you want to set clear expectations. So how many sessions will the sharing of the narrative be? What will you do at the beginning of the session, and who will the child read it to, and who will read the narrative during the session, the caregiver, the parent, or yourself? And then at the end, you don't want to forget the integration phase, which we're not going to go through during this presentation, but is a really valuable portion of treatment and should be 1/3 of your treatment. And this is one study that I just wanted to highlight it related to the trauma narrative and treatment length. And this study, which was done in 2011, found that after 8 sessions with the trauma narrative, 8 sessions with the trauma narrative actually proved to be the most effective and efficient at reducing parents' abuse-specific distress and children's abuse-related fear and general anxiety. So treatment doesn't need to be long, and a lot can be accomplished with 8 sessions and the trauma narrative. This study also found that 16 sessions without the trauma narrative actually produced the greatest increase in effective parenting and fewer externalizing problems. And this is an important finding to highlight, and is one that should be interpreted with caution, because the study talks about how during those 16 sessions, a great portion of treatment really focused on that parent management component of trauma-focused CBT. So that may explain why the externalizing behaviors was seen to be fewest in this model. So I'm going to stop there and open it for questions. And then, of course, you can always email me with questions as well.
Lindsay, thank you so much. There's so much for folks to wrap themselves around if they're first doing this work or doing this work for the first time. I'll just ask you a sort of a basic training question. If people actually want to get skilled at delivering this treatment, what do you recommend in these days and times for somebody just starting out and wanting to get tooled up?
Great. That actually is on this slide right now. So you'll see that there is a trauma-focused CBT webinar that you can complete, and the website is listed there. And that's a great intro to this model and really goes through it in its entirety. And then if you wanted to become a certified therapist, there are trainings that are offered throughout the country, and the link is on this slide as well for those.
And given the very current situation that we find ourselves in, I use as a sort of general statistic, 80% of us recover from traumatic exposure, only 20% go on to have PTSD. Given that we're heading into very stressed times, it's going to be traumatic for some people. What do you suggest that therapists who are new to this territory be on the lookout for as they're talking with parents about their children?
So I think that intake should include a trauma assessment as part of almost all intakes. So in the beginning of treatment, giving a measure like the trauma symptom checklist, just as part of the battery of measures that you provide. And also asking, if you're not giving a battery of measures, if you ask during the intake whether the parent notices these symptoms just started. So do they predate what's currently going on, or are they new symptoms? And can you potentially find a link between what's currently going on and those symptoms?
Is the trauma inventory you just referenced in the public domain?
It is not. It is not. So that is something that you would have to purchase. But there are, I can send a list of measures that are in the public domain that could be utilized. Also,
That would be really helpful.
Okay.
I also want to make people aware Division 53 of American Psychological Association has just launched, prior to this current situation with COVID-19, an amazing assessment website. So families can go there, they can fill out a bunch of questionnaires that are free in the public domain, and they're empirically supported. And they're encouraged then to print that out, save the PDF, and give it to the clinician that they're working with. I don't recall offhand if it includes any trauma measures. But I would recommend that to folks. Given that you're now going to be mostly working from home or a closed office, although I know it's different in your hospital, at least for right now, what are your thoughts about doing any of this work virtually? Have you ever done it?
I haven't done it virtually. In terms of providing, my thoughts are that you can provide psychoeducation to parents virtually. So that psychoeducation portion of the treatment and the parent management portion of the treatment can be done virtually. The work with the child, depending on the child's age, would really dictate how much you can be doing virtually. And of course, you also want to make sure you have a contingency plan. So if the child's symptoms increase, what can the parent do to support the child given the restrictions that have been placed on us?
Somebody who's asking, do you recommend using, it's in quotes, my TF-CBT workbook, the free online one with students in the school setting, if you're a social worker or a school psychologist? Do you have any familiarity with that?
Yes. So the workbook, there's also one for children as well. There's one for children and for adolescents, and you can utilize it. I say that that is only a starting portion. So you wouldn't want to just go through the workbook. You want to use that to facilitate some of the components, the practice components throughout. Now, depending on whether you're providing, lots of social workers or school psychologists in the school are limited to like 25-minute sessions. This isn't something that you could accomplish within a 25-minute session. So you'd want to make sure that you can find the time and that you structure the session so the child has a positive ritual at the end of session so that they're ready to go back to whatever subject they're going into from treatment with you.
We're going to apparently get you a larger video here. If you stop your presentation, we'll be able to see you larger. There we go. Cool. But I got to get back to the chat. Let's see. Some folks are asking about complex trauma and how that fits into this work, if you could address that.
So there's lots of research that talks about how trauma-focused CBT is very effective for addressing complex trauma. When you get to the trauma narrative portion of the treatment, you want to help decide with the child which traumas you're going to be focusing on, because remember that trauma narrative portion of treatment should only be 1/3 of the treatment. You don't want to be doing that the entire time. So ways to decide what trauma to focus on is which trauma is linked to the traumatic reminders the child is currently experiencing, and also what is the most significant. Sometimes what's the first trauma that the child experienced, or the one that's causing them the most distress. And you can get that information from both the child and from the caregiver. So yeah, I'm thinking of a specific situation that I had a child that was sexually abused for a number of years. And then when mom walked in on the abuse, the perpetrator punched mom in the face. And for that particular child, even though there were many times where the abuse was more significant, in like maybe I would have defined it as more significant for that particular child, that last time was actually the most significant because the trauma wasn't even the sexual abuse in her mind. It was watching her mom be punched because of what she did. She said that it was because of what she did at the time, which obviously was not because of her.
Thank you so much for being able to keep this commitment to share this time with us and your expertise. This is obviously a topic we're going to be revisiting. We had an amazing response. Over 100 people wanted to learn more about this. So thank you for your own exposure in tolerating this and doing a great presentation. We have a list of some things that people wanted and we will send. We'll send information about the Division 53 website. Lindsay, if you would send us whatever public domain stuff you're aware of, we'll get it back out to the folks. Also want to mention that because of the coronavirus, we are now fully doing our PCIT conference, which is scheduled for April 3rd. We'll be fully online in terms of presenters and attendees, and we'll send you a link for that. And if